38-year-old male, occupation by driver, residence of Kadalur, a right-handed individual, self-informant. Came with chief complaints of weakness of the left upper limb for 17 years, weakness of the right upper limb for 9 years, and weakness of the right lower limb for 4 years. History of presenting illness. Patient was apparently normal 17 years ago, after which he developed a weakness of the left upper limb in the form of difficulty in holding overhead support while standing and traveling in a bus. Initially, he was unable to sustain overhead support for a shorter duration for approximately 20 minutes, and this weakness got slowly progressed over the 1 year, and it progressed result in complete inability to lift left upper limb above the head. After 1 year, he noticed difficulty in folding his elbows and difficulty in holding the objects with the left hand and inability to hold the steering and gearing rod while driving, associated with thinning of the left arm followed by left forearm and hand muscles, and associated with history of sensation of looseness of limbs. This progressively worsened and he is completely unable to hold the objects in the left upper arm for 2 years after the onset of symptoms. And a history of difficulty in buttoning, unbuttoning the shirt, and using the left upper limb for toilet purposes. And 5 years later, he noticed difficulty in lifting the right upper limb, which was similar like left upper limb. Initially, he found difficulty in lifting the right upper limb over the head for combing, washing hair, and holding the comb. Simultaneously, he had a history of perception of twitching over the left arm, and sometimes it was generalized all over the body, and at present twitching only in the right pectoral region. In the next 1 year, he developed a history of difficulty in holding the objects in the right hand and difficulty in buttoning and unbuttoning and mixing of food and eating with his own hand and opening bottle caps. And he also noticed thinning of muscles of right arm, right forearm, hand muscles, and looseness of limbs. After 8 years, he had stiffness in the right lower limb, and progressively it got worsened, associated with the history of difficulty in getting up from the squatting position, climbing up and down the stairs, and history of difficulty in putting the leg into the slippers, and a history of difficulty in gripping the slippers while walking with awareness. And no complaints in the left lower limb. And no history of difficulty in lifting the head from the pillows, no history of difficulty in rolling over the bed or getting up from the bed, and no history of difficulty in breathing, and no history of diurnal variation type of weakness, and no history of tingling, burning sensation or pain over the both limbs, and no history of numbness, and no history of difficulty in appreciating hot and cold water sensation while bathing, and no history of difficulty in perceiving the clothes over the body, and no history of difficulty in perceiving the cell phone vibrations, and no history of difficulty in walking in dark places, and no history of band-like sensation or shock-like sensation, and no history of any root pain, neck pain, or back pain, and no history of memory disturbances or emotional ability, and no history of loss of consciousness or altered sensorium, no history of any trauma, no history of delusion, no history of hallucinations, no history of speech disturbances, no history of difficulty in perceiving or altered food smell, and no history of blurring of vision, no history of difficulty in differentiating the colors, no history of drooping of eyelids or double vision, and no history of difficulty in appreciating hot and cold water while washing face. No history of difficulty in chewing the foods, and no history of drooling of saliva or deviation of angle of mouth or loss of taste sensation. No history of hard of hearing or tinnitus or vertigo, no history of difficulty in speech or nasal regurgitation, and no history of difficulty in lifting shoulders, and history of mild difficulty in swallowing, and no history of swaying while walking, and no history of difficulty while walking through narrow passages, and a history of able to feel the bladder fullness, and a history of able to initiate the micturition and completely void, and no history of any bowel incontinence, no history of palpitation, giddiness, abnormal sweating, or no history of postural giddiness. Antecedent history, no history of any trauma, no history of weight loss, no history of recent vaccination, no history of exposure to pesticides, chemicals, or toxins, and no history of electric shock, no history of fever, cough, loose stools, abdominal pain, or rashes. Past history, No history of similar complaints in the past and no history of any previous surgeries. Not a known case of diabetes, hypertension, systemic cardiac disease, renal diseases, or thyroid and asthma. Personal history. Patient on mixed diet, normal sleep and appetite, normal bowel and bladder habits. Chronic smoker for 15 years, 5 cigarettes per day. Now he's a reformed smoker for 2 years. And occasional alcoholic. Last binge was three years ago. This is a family history. No history of similar complaints among family members. It's a married and non-consanguineous marriage, ma'am. 3 daughters and 3 younger brothers are there. No history of similar illness in the family and no extramarital affairs. And treatment history. Earlier, he used vitamin tablets, proton pump inhibitors, and riluzole for 3 months. But he found no improvement, and due to affordability issues, he discontinued the tablets. Now, not on any medications. Summary. 38-year-old male presented with insidious onset, gradually progressive, asymmetrical motor weakness of bilateral upper limbs and right lower limb associated with looseness and wasting of bilateral upper limbs, both proximal and distal, and twitching over the right chest and stiffness in the right lower limb with no involvement of sensory, cranial nerve, cerebellum, or bladder. So, from the history, it is a pure motor weakness. And both human and LMN type of involvement because human in the lower limb and LMN in the upper limb, looseness and stiffness. Possible structure involved, it could be corticospinal tract and anterior horn cell. Possible level cervical because of both upper limb and lower limb involvement.
Okay.
So possible DDs, motor neuron disease, cervical compressive myelopathy, HIV infection induced MND because he is a lorry driver by occupation, and query CV junction anomalies.
Okay, ma'am. We will analyze the symptoms, no?
Yes,
That is the purpose of these sessions, I think. So first, he is a very well-preserved person, very young man.
yes.
And at the age of 17, he developed difficulty in lifting the hand above the shoulder.
Yes.
So that at that point of time, that I think he was about 20 years, no? 20 years.
Yes, now 38, ma'am. The 17 years, 20 years, ma'am, approximately.
20 years.
Yeah.
So if there is a difficulty in lifting the shoulder, hands above the shoulder, first
Yes,
we will ask whether it was painless or painful.
Yes, ma'am.
It was painless, I hope.
It is painless.
Yes.
Painless.
If it was painful, you will think of certain conditions. If it was painless, you will think of certain conditions. So lifting the shoulder above without pain involves what structures?
Ma'am, without sensory involvement means we could thought like
So abduction of the shoulder.
abduction of the shoulder restrict. Yes.
There was no mechanical restriction. There is no pain. So straight away you can rule out any joint or capsule or ligament problems of the shoulder.
Yes.
And so it could be, which is the muscle which abducts the shoulder?
Initial 0 to 15 degree supraspinatus, ma'am. 15 to 90 degree by deltoid, ma'am. Overhead abduction or more than 90 degree is by trapezius.
So in this patient, what do you think? It was all involved or only one group of muscle was involved? He was not able to lift at any range, or if he supports the initial 30 degrees, could he lift above?
Initial 30 degrees, he could able to mild abduction can be done, ma'am. But overhead abduction and moderate abduction, more than the 30 to 40 degree, he couldn't able to do.
And after 90 degree?
He is not able to do, ma'am.
So there is first 30 degrees is better than the rest of the abduction. That's what you are telling, no?
Yes, ma'am.
So first 30 degrees is which muscle?
Ma'am, supraspinatus.
30 to 90?
It is by deltoid, ma'am.
Beyond that?
Trapezius.
So what is the nerve supply of supraspinatus?
Suprascapular nerve, ma'am.
Yes. What is the nerve supply for deltoid?
Axillary nerve.
Which is the nerve supply for trapezius?
Trapezius is by spinal axillary nerve.
Yes. So it is supplied by 3 different nerves.
Yes.
Of which apparently the first thing is spade and other 2 are involved. So is it at the nerve level? Is it at the muscle level or nerve level or anterior console level or root level or
Yes.
inside the cord, or is it higher than that is the question we will have to ask at that point of time if you has come to us also, no?
Yes,
So muscle level, would you like to consider?
muscle level, there is no diurnal variation, nothing was the neuromuscular junction. If it is there, no, there is no neuro weakness or nothing is there. Diurnal variation is not there.
Now, one thing, generally muscle diseases are
Proximal.
symmetrical,
Symmetrical
no?
and proximal.
Mostly they are symmetrical, whether they are inherited dystrophic muscle disease or metabolic endocrine muscle disease, the insult is common. So they are all symmetrical.
Symmetrical and
Is
proximal.
there any asymmetrical muscle disease you know of? So that is what should be your answer. If you think whether it can be at the level of the muscle, at that time we don't know, no? Now
Yes,
it is all fully evolved, no?
yes.
So any muscle disease that can be asymmetrical. FSHD, no?
Yes.
Facioscapulohumeral
Facioscapulohumeral
dystrophy. So at that point, he has a humeral dystrophy. So
Yes.
facioscapulohumeral dystrophy has got about 7 phenotypes. So it can be lower limb onset, it can be face onset, it can be upper limb onset, it can be distal, it can be proximal, no? So there are so many clinical expressions of facioscapulohumeral dystrophy. So when it is asymmetrical and purely motor, it is not wrong in thinking whether it is the beginning of a FSHD, no? So in the deltoid, what will be the thing you will find in FSHD? So in our patient, supraspinatus was relatively preserved, but deltoid is affected and trapezius is affected. So now what happens to deltoid in FSHD?
Hyper.
In case it's an asymmetrical muscle disease, yes, correct. Tell me.
Hypertrophy.
Deltoid will be usually spayed and it will be very bulky and it can be asymmetrical and resulting in a syndrome called poppy sign.
Yes.
It is called poppy sign. That is the upper part of the arm is very bulky and the lower part of the arm is wasted and that phenomena is called poppy sign. So deltoid will be very prominent. It can be asymmetrically prominent. One limb may be normal, other limb may be prominent.
Okay.
And the trapezius, will it be involved?
Facioscapular.
Can be involved.
It can be involved, ma'am.
Involved. And because there is winging of the scapula.
Scapula will be there.
What are the features of the winging of the scapula and trapezius involvement?
There will be prominent medial border of the scapula will be there.
Yes, that is winging.
Yes.
So what are the other muscles which produce winging of the scapula?
Serratus anterior.
Yes. Rhomboids, no?
Rhomboids.
Rhomboids, serratus anterior and trapezius. So rhomboids is a very small muscle. So it produces mild prominence of the mid 1/3 of the medial border of the scapula. And when you check for the rhomboids, you might find that it is weak and wasted. That is rhomboids. Otherwise, the main differentiation in a winging of the scapula is between serratus anterior and trapezius. Now tell me the points. One side you put serratus anterior, another side you put trapezius, and tell me the difference. That's what we will look at that time. If it is an evolving FSHD, one of the several phenotypes of FSHD, no? So what will be the features? So we will think one deltoid should be spared usually, and it will be bulky. Second, trapezius can be involved, and serratus can also be involved. Now just tell me the difference between serratus and trapezius. Both produce winging. No. Is there any difference in the winging of the scapula produced by serratus anterior and trapezius? Serratus anterior is a uniform muscle, no? It is inserted to the inner aspect of the scapula to the ribs, and it is there along the medial border throughout.
Yes, 8 digitations will be.
Yes, so serratus anterior produces uniform winging because it is there in the upper pole, it is there in the lower pole. So the scapula's upper pole and the lower pole wings, whereas trapezius is not in the lower pole. It is only in the upper part of the scapula. So it will be an upper scapular winging. for trapezius, whereas uniform scapular winging for serratus
Serratus.
anterior. That is the first point. Second point, because serratus anterior is there throughout, that winging is without rotation. The whole of the scapula wings and there is no scapular rotation. Whereas trapezius is there in the upper pole and the rest of the scapula, there is no muscle which can produce winging. So it's an upper scapular winging with rotation of the scapula. So it is winging with rotation. Trapezius is winging with rotation. Serratus anterior is uniform scapular winging parallel to the spinous process. So winging without rotation is serratus anterior. Winging with rotation is trapezius. Third point, because the trapezius elevates the skin fold by its winging in the upper part of the nape of the neck, it produces a hump there. Because the scapula, it is called scapular hump. So make the patient stand there and look from in front. You will find a scapular hump on the side of winging due to trapezius. Whereas winging due to serratus anterior, there is no rotation. So there is no scapular hump.
Okay.
That is the third point. Fourth point, trapezius produces squaring of the shoulder. Shoulder contour becomes squared. Whereas serratus anterior has no role in the nape of the neck.
Okay.
It will form a square.
That's correct.
Whereas normally it is a circle. And serratus anterior does not produce any influence on the nape of the neck.
Okay.
Then the fifth point is, because the shoulder is drooped on that side, the arm on that side will be lower than the opposite side in trapezius. In serratus anterior, arm is equal on both sides. Arm hangs equal on both sides. And the next point will be, serratus anterior winging is made prominent by pushing forward, because it approximates the in the medial border of the scapula to the ribs.
Yes.
Whereas trapezius winging is made prominent by abduction, by abducting the shoulder. So these are the points. So with that, we will see that whether my patient is having a winging of the scapula and deltoid is bulky, then it will qualify for a asymmetrical muscle disease like FSHD. So at the level of the muscle, you will think at that time, because
Yes.
these are the two muscles which can be involved. So then of course you will examine whole patient and see whether it is there or not. But
Okay.
you can consider. It is not wrong.
Yes.
Second will be the root. Supposing you take the roots which supply these muscles. C5 root supplies which are muscles?
C5 biceps, ma'am. Coracobrachialis.
Yes.
Biceps brachii.
Supraspinatus.
Supraspinatus and
Infraspinatus. Deltoid.
yes.
Biceps.
Biceps.
All are supplied by
Rhomboids.
C5 only. Rhomboids also. No, all are supplied by C5 only.
C5, sir.
So you have a selection within a radicular zone. You said that supraspinal. So if you think of a root supply, I'm just telling you, you know the diagnosis in your case. Just to approach the anatomy so that in another case, you will make a different diagnosis if indicated.
Okay.
So next, you think of a radiculopathy. So sensory, motor, reflex. 3 points we will say. Any root, you have got a zone of sensation, you have got a reflex, and you have got motor supply. The motor supply is so many muscles.
Yes.
But you find that only one muscle appears to be affected among all the muscles supplied by the same root.
Yes.
You are not having any sensory symptoms, irritative or destructive, referable to the root that supplies.
Yes.
So even though you thought of a C5 radiculopathy, there is only selection within a radicular territory. That is the term you use. C5 root supplies so many muscles. Even though patients may be symptomatic with one muscle, when you examine, you will find all the muscles supplied by that root are weak to various degrees. but you have a pattern called selection within a radicular territory.
Motor unit pattern.
Yes. So you have got a root pattern, you have got a anterior console pattern, you have got a plexus pattern, and you have got a nerve pattern in motor involvement. So nerve pattern will be the muscle supplied by that nerve and its sensation. Root pattern is muscle supplied by that particular root, whereas anterior console is selection within a radicular zone. So apparently, it seems that you have got a selection within a radicular zone where only one of the muscles supplied by that root is affected, whereas many other muscles supplied by that root are spared. So that is the pattern you are seeing. If it was acute, you would have considered a polio or polio-like illness. He was only 20 years because polio is eradicated, it can affect the adults now. When it is endemic disease, adults are already immunized fully and children will be vulnerable. Now that it is eradicated, of course, the vaccination is continuing. If it has stopped, that eradication is complete, then both adults and children will get the disease. So is it a polio or a polio-like illness? So anterior console pattern can be due to degenerative anterior console disease. Then you will find a selection within the radicular zone. If it is an infection which affects the anterior console like polio or polio-like illness, some of the ecoviruses, they produce polio-like illness, no?
Yes.
So what is the polio-like illness? Polio, what is the pattern?
Polio, ma'am, entire anterior horn cells will be involved, ma'am. So
it produces
element type.
Element only, all this is element only. Polio produces something called column pattern, column. No? You have got short column muscles and long column muscles.
Okay.
What is a short column muscle means? Like for example, you have got the short muscles of the foot and hamstrings. They are supplied by S2 segment. So it's a short column muscle. It is not sharing its supply with many segments. So short column muscles, if they are involved, they will be severely involved because that concerned segment becomes totally destroyed by the viral infection. Whereas long column muscles like quadriceps, it is on L2, L3, L4. So long column muscles, if they are involved only partly because only one segment of that column gets involved. So for polio and polio-like illness, we call it as a column pattern. What is a column pattern? Short column muscles, if they are involved, the degree of involvement is very severe. Whereas long column muscles, if they are involved, the degree of involvement is less. So that is the column pattern you will find.
Okay.
So it is a short column muscle only. Deltoid is a short column muscles, but for a column pattern, all the muscles supplied by that C5 should be equally weak. It's a short column muscles, C5 only. It is not sharing with many roots. So if the C5 is destroyed, all the muscles supplied by that C5 should go. That is not going. That is against a polio or polio-like illness.
Okay.
So root is over. And anterior console, whether it is degenerative, we thought the column selection pattern, and infective, we thought the column pattern.
Yes.
Then what other conditions can produce anterior console in a young man? It may be an evolving syringomyelia.
Syringomyelia can be that.
Yes. Syringomyelia can be totally missed if the patient is not telling you the sensory features and you are not looking for the sensory feature. And you may diagnose an anterior console disease. So syringomyelia, it involves anterior console crossing spinothalamic tract in that segment and the long tracts below that. But at one point when it is evolving, it may look like an anterior console disease. At that time, you have to carefully look for pain and temperature. Only when you look for pain and temperature very carefully in a suspended pattern in that segment, even if the patient is not complaining in a case like this, you will diagnose syringomyelia. Otherwise, you can miss it off. The same way it can present, no?
Yes.
Only thing, the suspended dissociated sensory loss is the clue. So that is the Because the syringe cavities dissect ventrolaterally. Ventrally is the anteroconsal, ventrally is the crossing spinothalamic, and laterally is the anteroconsal. Both go together. If that is there, it is a syringomelia.
Yeah.
Any other level you can develop wasting. In between we left is the plexus.
Yes.
So plexus generally diagnosed clinically only if more than one nerve coming from the same plexus is affected. That is not happening. In our case, there is a accessory nerve and a C5 root. It is not both coming from the same plexus. So very unlikely. So by this pattern recognition, this is called a pattern recognition. At that time itself, instead of breaking our head what it is, you do the pattern recognition. It is not fitting into a root, it is not fitting into the plexus, it is not fitting into a syrinx, and it is fitting into a selection within a radicular zone, which is very typical of anteroconsal disease. So that time only you can diagnose, provided you go to the pattern recognition exercise.
Okay.
So that is what we find at this point of time in this patient. All the duties you can consider and you arrange in the order of priority. Okay. When you examine, you will look for sensory involvement, all those things, and then you decide. So next symptom was flexion of the elbow, you said.
Yes.
Flexion of the elbow is applied by flexion of the elbow.
Ma'am, biceps and coracobrachialis.
Yes. So flexion of the elbow is used for what activity he was doing, flexion of the elbow?
For eating purposes and as well as for taking any objects to the mouth like that.
So then what he was doing?
Ma'am, I can't.
So when there is a significant biceps weakness,
Yes, ma'am.
Resulting in impaired capacity to flex the elbow,
Yes,
people do trick movements.
yes.
What is the trick movement? Brachioradialis is there.
Yes.
So brachioradialis is a flexor of the elbow in semi-prone position. Biceps is in the fully supinated position.
Supinated position.
Whereas semi-prone flexion is brachioradialis. So when there is significant weakness of the biceps, people will use the brachioradialis to flex. So they will hold the forearm in semi-prone flexion and flex it. That is called as what sign? It is called bartender sign. Bartender sign. So people who carry alcohol and things like that in a tray, it is said that both, I do not know, it is said that they keep their forearms semi-prone flexion and keep the tray on the hand and carry it, it seems. So it is called a bartender sign. So they will flex the arm only in the semi-prone position. Straightforward flexion is not possible. So semi-prone flexion will be adopted. That is called bartender sign. So now biceps seems to be affected. Whether the brachioradialis was normal, we don't know, because this type of history is not available to us now. So that is next, biceps is applied by the same root only.
Yes,
but your patient is not having any root pain and he is not having any roots, negative symptoms or positive symptoms of the C5 root, and it is not involved simultaneously, it is only sequentially involved. If it is a root, it will be simultaneously involved, not sequentially. No?
Yes.
So for all these reasons, still we do not think that C5 root is involved. And after that, patient developed, was unable to sustain overhead, then notice difficulty in holding the elbow, difficulty in holding objects with the left hand. So holding object is power grip, no?
Yes.
Power grip is by what muscle?
For holding.
You told holding.
For holding.
Which one?
For
flexor, long flexors. No?
Long flexor.
Long flexor. So it holding in the hand only, no?
Yes, yes, ma'am.
So holding in the hand is a forearm flexor.
Forearm flexor digitorum superficialis.
Yes. So palmaris longus, superficialis profundus.
Profundus.
So that is so it's a long flexors of the forearm. Long flexors of the forearm are supplied by what all nerves, roots, That way you tell me, ma'am, flux also, that same exercise.
Ma'am, for flexor digitorum superficialis, long flexors, mainly from median now, ma'am.
Which one, ma'am? Nerve.
Now,
Yes.
median now, ma'am.
What is the name of the branch that supplies these long flexors of the median nerve? It is anterior interosseous nerve.
Anterior interosseous nerve.
It's a pure motor nerve.
Pure motor nerve.
Anterior interosseous nerve. So pure motor only our patient is having. So whether it is an
Right.
anterior interosseous nerve,
Yes,
then
ma'am.
what is the root? Long flexors.
C6, C7.
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 C7. So C7 root means you have to, what are all the other muscles supplied by C7 root?
Ma'am, triceps.
Yes.
Extensor carpi radialis longus, extensor carpi radialis brevis.
Tell me. So it supplies shoulder adduction, that is pectoralis and latissimus dorsi. Elbow extension, that is triceps, no? Yes. Then wrist extension, wrist flexion, all are C7 only. So C7 is the long root which supplies the shoulder adductors, pectoralis, no? And latissimus dorsi, elbow extensors, wrist flexors, wrist extensors. That is the motor supply of the C7 root, and sensory supply is the middle finger. Whereas anterior interosseous nerve is a pure motor nerve and it does not supply trapezius or any proximal muscles. It only supplies the forearm flexors. So that way they are differentiated.
Yes.
And then we will see, so whether it is a root, even though we consider all the muscles supplied by the root are not affected. Yes, triceps and all is not so far affected. Adductors of the shoulder are not affected. There is no root pain. There is no sensory impairment in the C7 territory. So it's very less likely to be a C7 root. So power grip is involved due to long flexors of the forearm.
Yes.
So whether it is an anterior interosseous nerve level or the muscle level or the anterior hornsel level, all are possible. If you take anterior hornsel, there is definitely selection within the roots. You are not considering anterior interosseous nerve because other muscle involvement is not fitting into a mononeuritis multiplex. There is a condition called motor neuropathy with multifocal conduction block. That's a differential diagnosis for these kind of diseases. And it will exactly resemble anterior hornsel disease. Only electrophysiology will help us, where you will find that conduction velocity is impaired and there is conduction block. So it can exactly resemble this. So always remember whether it is a motor neuropathy with multifocal conduction block in every case because it's a treatable condition. So this looks like again selection within the C7 root, apparently. Long flex. Then you said the opposite limb also got involved in the same.
Yes.
Looseness means decreased tone, flaccidity, no?
Yes, flaccidity.
So flaccidity means what? Element
type of weakness.
So how do you differentiate element motor from UMN motor?
Ma'am, element there will be flaccidity, ma'am. In UMN it will be spastic, ma'am.
Yes.
And if it extends Babinski, ma'am. If it Babinski, UMN it will be extensor plantar, ma'am.
Yes.
And then deep reflexes, it will be exaggerated or brisk, ma'am. In UMN type. In element it will be absent, ma'am.
So in element, both superficial and deep. So there can be wasting. There can be both superficial and deep reflexes are absent. Whereas in UMN, superficial reflexes are lost, deep reflexes are exaggerated. And if that segment corresponds, you can have an upgoing plantar. And you will have wasting, which is due to disuse.
Disuse atrophy.
So it will be a uniform hypoplasia. Whereas in element, the wasting depends on the zone that is affected by the disease process. Whereas in UMN, it doesn't point to any localized disease process. It only indicates disuse. Then UMN, there is no muscle paralysis. There is only movement paralysis. Because there is no muscle paralysis, reflexly the movements can be elicitable, like yawning. A person with an upper motor neuron disease, When he is yawning, he may lift that limb which is weak. That is called pandiculation. So it's a reflex movement. It's a pathological synkinesis between yawning and movement of a limb. That is called pandiculation. When a patient yawns, he may lift that limb. Otherwise, he may not be able to do because there is no muscle paralysis. Whereas a person with muscle paralysis, by no activity, he will be able to move because it is completely gone. By any pandiculation or by any other movement. For example, you know that reflex. For example, you see a snake. A hemiplegic patient who is saying he is having great zero power lying in the bed might suddenly jump out of the bed. But then he will fall down. Because the voluntary movement component is needed, that will not be there. But reflex movement stimulated by some other stimuli is there. So voluntary reflex dissociation, both voluntary movement and reflex movements are lost in LMN disease. Neither voluntary movement is possible nor reflex movement is possible. Whereas in UMN, voluntary movement is not possible, but reflex movements are possible. But once the voluntary component has to be executed, he will fall down. When he sees a snake, he has to jump out of the bed, then walk. So he will jump out of the bed reflexly. But voluntary walking not possible, so he will fall down. So that is UMN. Then in UMN, there is loss of kinetic melody. Because of that, the finest movements get affected. Whereas in LMN, it depends on the territory involved. It has nothing to do with the fineness. It may be a fine movement or a power grip, depending on whichever muscle is affected. So these are the points to differentiate LMN from UMN. It is only a simple exercise which you have done in your undergraduate, but better to rehearse so that when you want to do it in the exam quickly, you will get all the points. Okay. Yes. Got all the points, no?
Yes, ma'am.
Yes. So this looks like a wasted limb with loss of power. And at present, we do not have any features to suggest a human involvement. All the features are suggestive element, and it is patchy. It is involving shoulder abductors, elbow flexors, and long flexors of the forearm at this point of time. So it looks like a not respecting a nerve or a root pattern. Apparently, it looks like a selection within a radicular zone. So that is confined to one upper limb at this point of time. So yeah, even though clinically it looks like a, at that point, what you will call this patient?
Bilateral LMN.
No, yes, you will call it as a, you have got a monomelic atrophy. It started like that.
Yes.
See, about 20% of the monomelic atrophy patients generalize. Rest of them do not generalize. So if you have seen him at that point, you could have thought about monomelic atrophy. And after the upper limb is involved, both upper limbs are involved, it can be abiotrophic. So bibrachial involvement. So that is the stage in which we are seeing this patient. So at this point, the diagnosis can be one, as you said, anterhonsal disease because of the pattern, respecting anterhonsal and pure motor. Second, there is a treatable condition which can resemble like this. There is thickening of the ligamentum flavum. It is surgically correctable. So that you should always look for in patients who come with specifically cervical lesions. No, it may be an anterhonsal pattern, but it is supposed to be, it can be a buckling of the ligamentum denticulatum, which produces a cord ischemia, resulting in an anterhonsal involvement. So those patients' progression can be arrested by removing the thickened ligaments and producing a surgical fusion of the cervical spine. So that is one treatable condition which will closely resemble bibrachial or monomelic atrophy in the cervical region. Always remember the DD. The next DD will be, so when we investigate, we will look for thickened ligaments. Then the third thing is syringomelia. Yes. Patient can be only motor from the history. Only when you examine, you might find the sensory loss. So the next DD will be syringomelia. Cervical cord is a favorite site for syringomelia. Yes. So that is also another possibility. Fourth possibility is foramen magnum lesions. Yes. So they produce what is called, what is the pattern?
Onion peel appearance over the face. Onion peel.
That is sensory loss. Otherwise, the pattern of motor weakness is called Z pattern. If you have got a anterior cord, posterior cord, central cord, hemicord, no? That produces several patterns. One is the Ellsberg pattern. Second is the Z pattern. The third is the pseudosyringomyelic pattern, no? So,
Yes.
so many patterns are there for diseases of the cervical cord. Z pattern happens in lesions with encircle the foramen diagram without compressing much, like lipomas, neurofibromas. Yes, they are soft lesions. So they go round the cord and pick up roots from one side and roots from the opposite side. And as a last sort only, it picks up the spinal cord. So at the early stage, Z pattern. Z means one upper limb, opposite upper limb, then contralateral lower limb, and then ipsilateral lower limb. Apparently, your patient seems to have a Z pattern. So that is foramen magnum. Brown-Sequard syndrome you have had, no?
Yes, ma'am. Hemisection of spinal cord will be there.
Yes. What is that? Sequard hemisectioning, correct.
Hemisection of spinal cord, ma'am. There will be ipsilateral element type of weakness. Will
And
be
what
there.
is Ellsberg pattern?
Ellsberg is high cervical cord lesion, ma'am. Patient will have anti-clockwise, patient will have weakness. Initially start in right upper limb and right lower limb and then left lower limb and left upper limb like that.
So it can be any upper limb,
Any of yes.
right or left.
Yes, right or left.
What is the point you have to tell about the upper limb involvement in Ellsberg? It is UMN.
UMN type of weakness.
It is not LMN.
LMN, it is UMN.
So you will not consider Ellsberg here. You can consider Z pattern, no?
Yes.
So Ellsberg, what is the pathomechanism? Why you should recognize these patterns?
At the level of lesion,
crossing at the level of crossing, if the lesion occurs, then they will have Ellsberg phenomenon.
Which one? No?
Crossing of the pyramidal.
That is in the middle, no? Pyramidal tracts crosses in the medulla, not in the spinal cord. No. So Ellsberg phenomena is due to intradural disease, where there is an ischemic involvement of the medial pyramidal fibers. In the pyramidal tract, the lamination is upper limb fibers are medial and lower limb fibers are lateral. No? Whereas in the posterior column, upper limb fibers are lateral and lower limb fibers are medial. So whatever pathology, if it picks up the medial pyramidal fibers first, then the Ellsberg happens. So how can an intradural, it's seen in intradural lesions. How can an intradural lesion produce an Ellsberg? By sitting on the mouth of the sulcocommissural artery, which supplies the medial pyramidal fibers. So the importance of recognizing Ellsberg phenomena is to understand that the ipsilateral upper limb involvement is due to infarction, not compression. Understood, ma?
Yes.
So you got arterial supply of the spinal cord. You have got transverse and vertical watershed areas. The transverse watershed is to the crossing spinothalamic, ventral horn, and medial pyramidal fibers. They are supplied by sulcocommissural arteries, which come from the arteria corona. Yes. So if there is a lesion sitting at the mouth of the sulcocommissural artery, which supplies the medial pyramidal fibers, patient will get Ellsberg phenomenon.
Okay.
So even if you remove the tumor, only the compressive component will improve. Whereas the part affected by infarction may not recover. So patient might say that even if I do not recover my leg, it's okay, I want my right hand. So if he has had a Ellsberg phenomena, you will give a guarded prognosis. Yes, sir, you have an Ellsberg phenomena. Your right lumb involvement is not due to compression. It is due to infarction of the sulcocommissural artery. So that will not improve with the decompression. So Ellsberg phenomena is for prognostic relevance. So the heralding symptom is due to infarction. So that is the thing. So apparently this looks like an Ellsberg. Sorry, Z.
Z pattern.
So all these become differential diagnosis. Is it a syringomelia, or is it a foramen magnum tumor, or is it a ligamentum dendriculatum thickening, which is surgically amenable, or is it an anteroconsal disease which started as a monomelic and became by abiotrophic?
Yes, ma'am.
Then you develop stiffness of the lower limbs. Both lower limbs, no?
Ma'am, no, ma'am, only right lower limb, ma'am. Left is
Only
on.
right limb.
Yeah,
Right lower limb.
right lower limb. Ma'am.
The illness started in the right upper limb, and now it is not the Z pattern. It is the right lower limb. With the Z
Yes.
pattern, it should be left lower limb. So he developed stiffness of the right lower limb, means which corticospinal, which part of the neuroaxis can produce that right lower limb stiffness?
Corticospinal tract of.
So it is definitely upper motor neuron
motor
because
neuron
it is
type.
stiffness. Upper motor neuron above L1 in the spinal cord.
Yes.
So it can be in the spinal cord above L1 only.
Yes.
So there are some conditions which involve specific tracts. They are called tractopathies.
Okay.
No?
Yes.
So is it a corticospinal tract involvement above L1 segment? Second, it can be anywhere from L1 to cervical cord, or it can be a monoparesis, cortical monoparesis. No?
Yes.
So pure motor involvement of the right lower limb can be anywhere in the spinal cord above L1 segment,
Yes.
or it can be up to the motor cortex. Anywhere it can be responsible. So how you will differentiate?
Ma'am,
If you have a reflex level, so when you examine, only the lower limb is stiff, and the reflex, abdominal reflex, other things are not involved. The reflex level corresponds to only the lower limb, then it is at the level of L1. So if you have higher reflex changes and higher level of like upper limb also stiff, it's already weak. So it is wasted and weak. The stiffness cannot manifest even if it is there. No.
Yes.
So in this case, it's going to help you. Depending on the reflex level and the motor level, you can identify which is the level. Most important is the cortical monoparesis, where you will find, if you find that there is a seizure.
Yes.
If you get a seizure,
That is-
you will think it could be cortical, parasagittal meningiomas, no? Fox cerebral tumors.
Yes.
The second, you may have cortical sensory loss. Sometimes you can get a bladder which resembles a cortical bladder. So cerebral monoparesis will have seizures. Upper level will be very vague and ill-defined, and they can have a cortical bladder, and they can have cortical sensory loss because the cortical sensory zones are close by. So
Yes.
lower limb might show cortical sensory loss. That will be the point of a cortical monoparesis. So we'll examine and we'll decide. So
Yes.
at this point, patient has got LMN in the upper limb
And UMN
and
in the
UMN in the lower limb.
lower limb.
Lower.
Yes.
So LMN plus UMN in the lower limb. First, you should think of a cervical compressive pathology only.
Yes.
You will not first only diagnose motor neuron disease because it is treatable conditions. Craniovertebral junction anomaly, you have said correct.
Yes.
So you will think of a myelopathy with a radiculopathy. Even though all the points we have discussed, still you will consider and investigate like that. Only atypical presentations are there.
Yes.
So whether there is a CV junction anomaly, whether there is a syringomelia, whether there is any intradural compressions, no?
Yes.
Or is there any cord encircling tumors which has only picked up one limb and opposite limb will be picked up later. So all this becomes and anti-tonsil disease, of course.
Okay.
They are all becoming differential diagnosis. At this point of time, you have not got any fasciculations, any fibrillations.
Complaints of twitching over the
Which one, ma'am?
twitching over the right pectoral
His
region.
conduction?
Yeah, ma'am. He gave complaints.
So some fasciculation is there.
Yeah, ma'am.
So what is that called? What are all the various positive phenomena? So far, we got only negative motor phenomena.
Yes.
What are all the positive motor phenomena, you know?
Ma'am, fasciculation, fibrillation,
Yes.
myoclonus,
Yes. Cramps, contractions.
cramps and contraction. Ma'am.
Contraction. So what is a fibrillation?
Fibrillation is a contraction of a single muscle fiber, ma'am, due to denervation hypersensitivity to the chemical environment.
Very good. What is a fasciculation?
Fasciculation is a spontaneous contraction of motor unit, ma'am.
Very
So due to denervation of the terminal axon from the nerve cell body.
Very good. What is a myoclonus?
Myoclonus is a shifting vermiform movements.
Very good. Wonderful. What is a cramp?
Cramps is it can be a physiological condition as well as due to some other metabolic or electrolyte disturbances, ma'am. Patient will have pain in the muscular fibers, contraction of the muscle fibers.
It's a painful shortening of the
Painful
muscle
shortening of the
due to
muscle.
energy deprived state.
Yes, ma'am.
It can be physiological if it
Physical as
is
well as,
unaccustomed exertion,
yes,
and pathological if it is happening in accustomed exertion.
yes,
And pathological cramps are electrically silent,
silent.
whereas physiological cramps are electrically active. So if you do an EMG needle, pathological cramps like myophosphorylase deficiency, metabolic disease, you put a EMG needle, it will not be firing.
Oh.
Whereas physiological cramps, you put a needle, it will fire, act.
Active.
So it will produce discharge. So these are the points. So
Yes.
you have got fasciculations. Fibrillations are visible only in
In the
the tongue.
Yes.
In other areas, fibrillations are so small, it will be masked by the big muscles.
Yes.
And you said some swallowing difficulty. What is the swallowing
Yes.
difficulty?
Ma'am, patient while eating, he had difficulty in swallowing, ma'am, pushing the food backwards, ma'am.
So oral phase.
Oral phase it is affected.
Oral phase means whether the tongue or cheek muscles or
Tongue.
orbicular perioral muscles,
Tongue, ma'am.
tongue muscles.
Tongue.
So tongue muscles are in, so
But
it is the oral phase. Food falls out through the middle of the mouth. He's not
No.
coughing while swallowing.
No, ma'am, no complaints of cough. Now only he started telling this complaint, ma'am. Previously it was not there. Now only he noticed like mild difficulty while swallowing.
So if it is in the oral phase, it is either facial muscles or it is either trigeminal muscles or is it the lingual muscles. So trigeminal muscles is for chewing.
Chewing.
Facial muscles is for closing the mouth. And the lingual muscle is for pushing the food to the back of the throat. So
Yes.
if it is pushing the food to the back of the throat that is affected, it indicates tongue muscles.
Yes, ma'am.
So I can say my patient has got a swallowing difficulty in the oral phase.
Yes, ma'am.
And you have got oral phase, pharyngeal phase, esophageal phase.
Esophageal phase.
So your patient has got a oral phase, and in the oral phase, it is pushing the food bolus to the pharynx. So that points that tongue is probably getting involved. Okay, go on. On examination. So these are the DDs.
Yes,
Sometimes we have seen exactly this presentation is vertebral artery aneurysms.
No.
And arteriovenous malformations coming from the vertebral artery. Because the vertebral artery goes to the through the pica branches, it descends the cervical cord. So arteriovenous malformation in that territory can go on as a condition like a cervical myeloradiculopathy for a long time. We have seen such cases also. So apart from the syringomyelia and other kinds of myeloradiculopathies, you will also put vascular anomalies coming from the vertebral artery and CVG anomalies and foramen magnum mass lesions. Okay. On exam, HIV, I will not consider because it is such so many years. And HIV generally doesn't produce Anderson disease. It produces peripheral neuropathy. Severe wasting, but that will be symmetrical. Symmetrical wasting and bulk loss. Otherwise, it produces acute and chronic neuropathies. So what else you have put? What other did you put there?
See, motor neurons, cervical compressive myelopathy.
Yes.
CV junction.
Agreed. Yes, ma'am. On examination?
On examination, patient is conscious, oriented, thin build, poorly nourished, ma'am, and no pallor, icterus, cyanosis, clubbing, lymphadenopathy. Height was 162 centimeter, weight is 50 kg, and BMI is 20.2. Neck to height ratio is less than 1:13, ma'am. And no neurocutaneous markers, no peripheral nerve thickening, no cutaneous markers of malignancy, and wasting of arm, forearm, and small muscles of hand is there, ma'am. Left more than right. Fasciculations are seen over the right chest. Fasciculation video, ma'am.
Yes, ma'am.
Fasciculations.
Yes.
And vitals, Pulse rate is 80 beats per minute, which was regular in rhythm, normal in volume, no radial delay, no radiofemoral delay, all peripheral pulsations were felt. And BP 110/70 per mmHg measured in right upper arm in supine position, and respiratory rate is 114 per minute, and abdominal thrust. And SpO2 it was 98% on room. And coming to CNS examination, higher mental functions. He is a right-handed individual, conscious, oriented to time, place, and person. Memory is immediate, recent, and remote memories are intact. Speech and language is intact, and no dysarthria. And MMSE is 30 by 30. Cranial nerves. First cranial nerve is normal, ma'am. Able to perceive smell of coffee and other things. And visual acuity is normal, ma'am. Checked by Snell and chart. And color vision is also normal, ma'am. Checked by Ischia chart, ma'am. And cranial nerve 3, 4, 6 is normal, ma'am. No ptosis, no squint, extraocular movements are full, ma'am. And no and trigeminal nerve, sensory sensation over the face able to perceive, ma'am. And corneal and congenital reflex are present, ma'am. And seventh cranial nerve, no motor and sensory component of seventh nerve is normal, intact. And Rennes and Weber's is normal. Air condition is bone conduction, and no lateralization was there. And 9 and 10 gag reflex is present, ma'am. And then palatal movements equally on both sides, ma'am. And trapezius and sternocleidomastoid mustard muscle, patient can able to struck the shoulders, ma'am. And then 12th nerve involvement, tongue flaccid, ma'am. Tone is flaccid. And then fibrillations were present, ma'am. And then patient had a mild difficulty in protruding the tongue.
Protruding is also.
Yes, mild difficulty is there. There is atrophy of the tongue, ma'am. No mild fibrillations are there.
Agreed. Yes, yes.
And coming to motor system, ma'am. Attitude, patient is in supine position. Bilateral upper limbs are adducted at the shoulder joint. Elbow is extended, and bilateral lower limbs are extended at the hip joint, knee joint, and plantar flex. Bulk inspection, there is a gross wasting of bilateral upper limb, ma'am. Wasting of bilateral small muscles of hand, left more than right, ma'am. So this is the picture, ma'am. So there is a gross wasting over the deltoid as well as all over the body, ma'am. And there is a small muscle wastings of the hand, ma'am. Thenar is atrophied as well as the hypothenar also is there, ma'am. And then there is a first intraosseous, first web space also mild wasting is there, ma'am, in this patient. And my guttering also is there.
Mild clawing also.
Claw hand is not there, ma'am.
Not there?
Not there, not there.
This little finger and the ring finger appears. Plus maybe the posture he kept like that. Huh?
Posture he kept like that, ma'am. But no claw hand.
Okay.
And bulk, ma'am. Bulk, right arm and right and left, ma'am. In 10 centimeter above the medial epicondyle of the arm, it is 18 centimeter, and left side it is 17 centimeter, ma'am. And in the forearm it is 17 and 17 centimeter, and in the leg thigh level it is around 46, ma'am, on both sides. And in the leg, in the right it is around 32, and the left it is 31 centimeter. And tone, ma'am, bilateral upper limbs were hypotonia, and then left lower limbs in the right side it is hypertonia, ma'am, but left side it is not involved, but patient is having increased tone, ma'am.
So weakness is not there, but tone
weakness is not there, but tone is increased. And then
that is possible, ma'am.
Yes. And then power, ma'am. Power upper neck it is 5 by 5, ma'am. In right upper limb, shoulder joint it is around 3 by 5. Abduction, adduction, flexion, extension, internal rotation, and external rotation is 3 by 5. In the left side, it is around abduction and adduction is 2 by 5, ma'am. And flexion, extension, internal rotation, and external rotation is 1 by 5, ma'am. And in elbow, flexion and extension in the right side it is by 3 by 5. In left side it is 0 by 5. He has difficulty in using total waist. And in wrist, flexion and extension in the right side it is 3 by 5, and left side it is 0 by 5, ma'am. And hand grip, in right side it is about 50%, ma'am, and left side it is around 10%. And the spinal muscles of hand, when we examine the abductor pollicis longus, in the right side it was 2/5, and left side it is 0/5. Ma'am. Abductor pollicis brevis is 1/5, left side is 0/5. Palmar interossea and dorsal interossea, right side 1/5, and left side it is 0/5. And then lower limb in hip flexion, extension, adduction, abduction, it is 4-/5, ma'am. And internal rotation and external rotation is 4-/5. In left side it is 5/5, ma'am, because left side it is not involved. And knee flexion and extension is 4/5. In left side it is 5/5, ma'am. And ankle dorsiflexion and plantar flexion are 4-/5, and left side it is 5/5. Coming to superficial reflexes, ma'am. Corneal reflexes is present on right and left, ma'am. Conjunctival also present. Jaw jerk is absent, ma'am. Abdominal reflexes are present. Cremastic reflex is present, ma'am. Bulbocavernous and anal we didn't do. Plantar it is extensor, ma'am. Bilateral extensor. And deep tendon reflexes, ma'am. In upper limb, biceps, triceps, and brachioradials are absent in upper limb, both upper and both the right and left, ma'am. And then a knee jerk and ankle jerk is exaggerated in the right lower limb and left lower limb. When we examine the clonus, there is no clonus. And Beaver's sign, it is negative. And sensations like crude touch, pain, temperature, everything was normal, ma'am. Fine touch, proprioception. There is no sensory deficit, ma'am. Patient can able to localize tactile localization, 2-point discrimination, stereognosis, everything was normal. And then cerebellar signs, there is no titubation, no nystagmus, ma'am. And in the upper limb cerebellar examination, power is less than 3/5, so we couldn't able to.
What is the relevance of looking for? What is the relevance of looking for cerebellar signs? Supposing it is a CVG anomaly with Arnold-Chiari malformation. No?
Ma'am, SCA3 can present like ALS like manifestation.
But it will not be this much asymmetrical. No?
Sorry.
So grossly asymmetrical, and cerebellar is not at all there. But the relevance in a case like this with the Z pattern is Arnold-Chiari malformation.
Okay.
So supposing you find even a subtlest cerebellar sign, it goes into autonomic is normal. No.
Autonomic nerve system is normal, ma'am. There is no postural hypertension, no abnormal sweating.
SCA3 will be the last one you will consider.
Yes, okay.
You will consider a CVJ. That is why you are looking at the cerebellar. Okay.
Spine and cranium is normal, ma'am. And then other systems, CVS S1, S2 are no murmur. Respiratory system, bilateral RNT was there. Normal vesicular breath sounds, no added sounds was there. And upper abdomen, soft, non-tender, no organomegaly. Diagnosis. A case of insidious onset, gradually progressive, asymmetric L1 type of weakness of bilateral upper limbs in the form of wasting and fasciculations, and the UMN type of weakness of bilateral lower limbs in the form of spasticity, ma'am, with the involvement of 12th cranial nerve nuclei in the form of flaccid tongue and the presence of fibrillation with no sensory involvement, cerebellar involvement, no bladder and ANS system involvement, ma'am. So deficit is purely motor involvement with both features of UMN and
pure
LMN.
motor, LMN plus UMN. Agreed.
UMN,
No?
yes, yes, ma'am.
Pure motor, LMN plus UMN, or pure motor, LMN, or pure motor, UMN. These are the different bedside classification of anti-consults. Purely LMN, purely UMN, LMN plus UMN.
Yes,
so LMN plus UMN favors anti-consult disease,
yes,
but still that pattern of evolution, I would still like to keep in my mind high cervical cord pathology, because upper limbs only LMN and lower limbs only UMN. The typical MND pattern is what? LMN in the zones where you have UMN.
Yes.
You see, you have brisk jerks in the upper limb and there you find wasting. That's a typical feature. But here, you don't find any wasting in the lower limb. So you the classical presentation of UMN in anti-consult disease, you will have evidence of LMN in the areas where there is UMN.
Yes.
So that is called LS scoral criteria. No?
Yes, ma'am.
But you are not finding LMN in the area of UMN involvement.
Yes,
so that's an odd feature. And he's a young person, and it is so asymmetrical subacute evolution. Still, I will keep in mind high cervical cord problem, which can also involve the tongue muscles. And actually, we have seen patients with CVG anomaly going on as MND long time. By the time you diagnose, it becomes very late. Second thing I will like to consider, instead of the degenerative anterior disease, no?
Yes, ma'am.
What are the pathomechanisms in anterior disease? One is
Ma'am, first main is loss of pyramidal cells, ma'am, from the bed cells layer.
so one thing in young people, it may be superoxide dismutase
Dismutase
deficiency, genetic.
Yes,
So genetic, young people, genetic possibility of superoxide dismutase deficiency.
yes,
Whereas in all age groups, excitotoxicity due to N-methyl D-aspartate toxicity or slow virus diseases, autoimmune disease,
diseases, paraneoplastics.
all these possibilities are considered. Considering excitotoxicity only, riluzole is used.
Yes, ma'am.
Considering the slow virus. Slow virus is considered because after polio in childhood, patients develop anterior disease later. So post-polio slow virus disease, based on that, amantadine hydrochloride is used.
Yeah.
No?
Yes,
And the immune-mediated mechanism is postulated based on pathological study of spinal cord specimens in patients who died, where inflammatory deposits were demonstrated. So people gave cyclophosphamide and immunomediator therapy. And genetic is superoxide dismutase. But young person, bulbar involvement, you can also look for, there are atypical young MND, Madras motor neuron disease, is the person having deafness. No?
Yes, yes,
Then there is a condition called violet T, some Verneuil's violet T syndrome, where there will be bulbar muscle involvement. That is coming under the category of riboflavinopathies.
Yes,
Riboflavinopathy, because it is treatable. It's called violet T. Verneuil, okay, some one word is there. That time,
BVVL, ma'am.
which one, ma?
BVVL, ma'am.
So that bulbar muscle and even the other cranial nerves can be involved, and young person, and so that is responding to a high dose of riboflavin.
Okay.
So considering the young age and bulbar involvement, you can do the genetic assessment for riboflavinopathy, or if it is not there, also I will give high dose riboflavin. The recommended dose is 300 milligram.
Yes.
There is a tablet called Ribofam. It is 300 milligram. There is nothing to lose by giving that. So treatable causes, CVG anomaly, still I will consider because of the grossly asymmetrical and very slow evolution of the syndrome.
Okay.
And second, I will consider riboflavinopathies, because degenerative disease I don't like to diagnose. That will be the last thing you will diagnose. Otherwise, he'll die now, no?
Okay.
Bulbar involvement, he will die. The riboflavinopathies are at least arrestable with high dose riboflavin.
Okay.
So these two possibilities you should keep in mind. Either you can do the genetic analysis, if not possible, at least try giving high dose riboflavin for a period of 3 months and watch what happens to the patient. So apparently you can say LMN plus UMN, it looked like a monomelic atrophy of the left upper limb, which generalizes in 20% of patients. So it can be that group. Other onset MNDs, one is the Madras motor neuron disease, where you can have deafness and cardiac involvement. No?
Yes.
Then in males, you have got a trinuclear repeat expansion disorder, Kennedy syndrome,
Yes, ma'am.
where they will have gynecomastia.
Gynecomastia will be there.
Yes. Then third thing, I will not like to leave off motor neuropathy with multifocal conduction block for the reason that it started in the upper limb. Forearm muscles are significantly involved, but upper motor neuron involvement is not the feature. So that is less likely. And then there are other variants or Mills variant. You heard of Mills variant?
Mills hemiplegic variant.
Yes, it's a hemiplegic. So it is not hemiplegic, it is a triplegic.
Yes.
So it is not the hemiplegic variant. So it could be a monomelic, which became generalized with LMN and UMN, and possibility of MND is there, but would like, considering the young age and the asymmetrical pattern and absence of LMN in the UMN involved areas and bulbar involvement, I would like to rule out treatable conditions still and investigate for a CVJ problem and riboflavin.
Okay.
So even if nothing comes out, you can give riboflavin. No?
Okay.
You can give and see.
Okay.
So investigations are done, huh?
Ma'am, no, ma'am. Routine investigations we have done, ma'am. Serology negative and other VDRL, everything.
Imaging not done, no?
Imaging not done. We are planned to do imaging and EMG, ma'am.
Okay. EMG you will look for motor conduction block and conduction velocity to do motor neuropathy multiple conduction block.
Yes.
But that will not produce upper limb in upper motor in the lower limb. So that will only help to confirm the diagnosis.
Yes.
Where nerve conduction is expected to be normal, increased spontaneous activity and innervation pattern.
Okay.
That's all.
Yes.
Imaging is important.
Yes.
The trial with riboflavin is definitely worthy.
Okay. We'll try.
Riluzole helps only in postponing the ventilatory stage by about 3 months.
Yes.
Doesn't help in any other way.
Yes.
Whether it really helps also, we don't know. Because we are not doing a control monitoring and there's a spectrum of disease. Each person differently behaves. So you cannot even do a proper control study.
Yes.
So we don't know. Okay. Any question, ma'am?
Ma'am, can a ALS patient be alive for 17 years, ma'am?
No, ALS patients live longest in Indian population. The age of survival is up to 11 to 12 years.
Okay,
but ALS is generally, even though this we will call it a young onset underconsult disease rather than the typical ALS. As I told, we should always remember the differential diagnosis, which should be ruled out. Because I have picked up vertebral artery aneurysms labeled as MND and CVJ anomaly long time. Bulbar involvement also happens, and by the time patient becomes inoperable. And riboflavin, I would like to not forget at all.
Okay,
but ALS people live longer in Indian population. Longest survivors 11 to 13 years are reported in literature. Anything, ma'am? Any other?
One more doubt, ma'am.
Yes, ma'am.
In this abductor split hand sign, abductor pollicis brevis and first palmar dorsal intrasay is affected, no, ma'am. Why that muscle alone it is affected, ma'am? Any theories?
You see, it is said that muscles which have maximum concentration of mitochondria are less vulnerable to change. So depending on the proportion of mitochondrial distribution, there is picking up of muscles. So pattern generation is there in anteroconsal disease. Pattern generation is there in muscle disease. Muscle disease pattern of selectivity is depending on the cytoskeletal structural protein that is affected in that particular muscle disease. In anteroconsal disease, it is said that it is the population of mitochondria. The eye muscles are not getting involved, no?
Yes, ma'am.
Because they are just having maximum mitochondria. So that is the explanation given. Any other question? No. Very nice presentation. And you answered all the questions wonderfully. So congratulations to you and your teacher. Very much, because teachers shape us into what we are. And you are very well motivated, because even though I cancelled, it was beyond my control, because I work in a very small hospital and I have no students, I have no assistants. It's a private hospital dealing with military patients, no? And an emergency case came and I only have to do for thrombolysis, all sorts of things. So even though I postponed it to 8 o'clock, still I could not make it. So I like to see young students, because now I am retired and old, na? So talking to you all is an opportunity. You know, I enjoy that. But unfortunately, I made you waiting and I could not do that. I'm really sorry. Today's class, I really enjoyed your presentation. Wonderful, ma.
Thank you.
So congratulations to you and your teacher.
Thank you, ma'am. Thank you. We learned a lot, particularly even the strata layering of motor neurons. That's how they do not affect as a root sort of a thing. Few muscles are being spared, few are being affected. So that's a wonderful learning. Second thing is that, madam, because the patient had initially had generalized fasciculations, but subsequently most of the other fasciculations have died down. So
Yes.
that also I think is little
That
suggestive of
indicates
the
worsening
motor
of the
neuron.
disease, sir.
Exactly. So I feel that that is little pointer to that.
Yes, sir.
And the other point is that typically, which are the things being spared in a motor neuron disease, particularly amyotrophic lateral sclerosis, has also happened in this patient.
Yes, eye muscles, triceps.
Yeah, bladder and everything.
Yes.
All that has been, which typically are being spared, also have been spared in this patient. So that is also another thing pointing to that.
Yes.
Third is your point that we have to roll out a treatable cause and
The
riboflavin
only reason.
in that dose. That is definitely, we will do that, madam.
So long duration with sparing of bladder, sparing
Yeah.
of sensation is definitely favoring a degenerative process. But we will not miss a treatable condition. in
Treatable cause,
young person.
definitely, madam. Definitely.
Thank you, sir. Thank you so much, sir.
Thank you, ma'am. We learned a lot, and we